Okay, I think welcome the experts come from different countries. I think we can start now. Nick, please help permit the other experts if there is invitation. Okay, now let's start. Ladies and gentlemen, good morning, good afternoon, and good evening for friends from different countries. I'm Bob, the TS manager of Rainmed. Today, I'm on behalf of Rainmed to welcome you to attend our online webinar. In the first half of 2020, we held several webinars successfully. The audience spread to dozens of countries and regions. Hundreds of doctors and distributors. We met more new doctors and distributors every webinar. At the meeting, we discussed various emerging technologies and trials for cardiovascular medical imaging diagnosis. Rainmed CFFR system has a high accuracy rate and avoids injection of adenosine. Diagnosis is faster, more economical, convenient, and accurate. And it can help doctors diagnose coronary artery stenosis more accurately. It's widely priced in clinical application in large hospitals. Okay, today before we start the webinar, I'd like to introduce our company to you firstly. Rainmed Medical Technology Inc. is a high-tech enterprise focusing on the research and development of accurate diagnosis and treatment of cardiovascular and cerebrovascular disease medical devices. Our device Flash Angel CFFR system had got the CE mark certificate and NMPA verification in 2019. Flash Angel CFFR system is used to evaluate the physiological performance of the stenosis on coronary arteries, and the new technology had been approved in the trial Flash FFR, which can get 95.7% diagnostic accuracy based on the verification of pressure gate wear. Because of the excellent performance in clinical application, such as non-invasive, easy operated, high efficiency, lower cost and risk, more and more demonstrations are ongoing in international and domestic market now. Now, a post-marketing clinical trial is ongoing in domestic market. At the same time, our systems are on the way to the office of our IAB team in Europe, Japan, South Korea, Ireland. As we know, except the normal lesions, bifurcation lesion is common in the stenosis, while it couldn't be evaluated by normal quantitative methods. Fortunately, CFFR system can give us a good answer. Today, we are fortunate enough to invite Professor Zheng Bo, the Director of Department of Cardiovascular Medicine at Peking University People's Hospital. The main research interests of Professor Zheng are as below: diagnosis and treatment of coronary heart disease, coronary intervention, intracoronary imaging and functional examination, coronary heart disease examination, diagnosis and treatment of acute myocardial infarction, interventional treatment of resistant hypertension. In addition, Professor Zheng is the Fellow of American College of Cardiology, Fellow of European Society of Cardiology, and the Fellow of Asian Pacific Society of Interventional Cardiology. Next, Professor Zheng will share the research in the field of FFR as well as the CFFR cases in bifurcation lesions with us. During the presentation, if you have any question or doubt, please kindly drop the questions into a studio. Then we will organize to answer the questions at once. At the same time, we will close your microphone. Okay, now let's welcome Professor Zheng. Welcome.
Hello everyone, I'm Zheng Bo from Peking University First Hospital. It's really my pleasure to be invited to share our experience and research progress of FFR and angio-based FFR in PCI with coronary bifurcation lesion. As you know, the coronary artery bifurcation lesion account for about 15% to 20% of all PCI cases. And it is one of the most challenging coronary artery disease that lead to lower success rate of PCI and poor long-term outcome. And during the interventional treatment of bifurcation lesion, the interventional cardiologist needs to decide whether the side branch needs to be treated or not, and whether we should put a stent or just do POVA. And according to the recommendation of the European Bifurcation Club, provisional strategy should be the first line choice, and the simple, the better. However, there is a crucial question that is when and how we should do provisional side branch intervention. To answer this question, we have to carefully evaluate the bifurcation lesion, and mostly according to the angiography. And based on angiography finding, and the most common classification is Magna classification that refers the proximal and distal main vessel and the ostial side branch. And if the main vessel and side branch are involved simultaneously, and it will be defined as the true bifurcation lesion. Actually, considerable bifurcation lesion will be the true bifurcation. One study just based on IRIS will show that more than 80% lit-to-man bifurcation lesions are so-called the true bifurcation. And also, we have several predictive models help us to differentiate the bifurcation from the simple and to the complex. One study from China, from Professor Chen Xiaoliang, the definition study, and they had, as you see, the 6 criteria, 2 major and 6 minor, and if the patient with the bifurcation is match the complex bifurcation criteria, and they should receive the double stenting surgery. But if not, if you just, there is a simple bifurcation lesion, you just put 2 stents and you see the clinical outcomes is less favorable. So this definition criteria help us to differentiate and to help us to make decision and how to treat bifurcation. And another one is the V-resolve score. It's also from China. And as you see, the risk factors including tract distribution and the main vessel tiny flow rate before stenting and pre-procedural diameter stenosis of bifurcations or bifurcation angle diameter ratio between the main vessel and the side branch and diameter stenosis of the side branch before the main vessel stenting. And this V-resolve score is very interesting. It's not only focused on the angio finding just as baseline, but also the angio finding just after the pre-treatment by the balloon. And there is a cutoff value if the V-resolve score greater or equal than 12, and the risk of the side branch occlusion is much higher than those just less than 12. But as you know, the predictive model is based on the angio findings. There's huge limitations only by the angiography. So there will be another one. And another tool is from the intravascular imaging. And you see the IRIS and OCT. We can provide, I think, much more precise anatomical information. As you see, the the ostium of the Sept branch, for example, from the distal lateral bifurcation, the circumflex, if the MLA is less than 3.7 or the PET burden greater than 56%, there would be the circumflex compromises after the main vessel is from the LAD to retinal crossover stenting. And another one is from OCT. And we focus on the morphology of the cornea. If the angle of the cornea is small, and if the distance from the tip of the cornea to the proximal ostium is very short, and the Sept branch compromise risk is much higher. But the intravascular imaging cannot predict the significance of the functional assessment especially after the main vessel setting. Just as we show the picture right, and you see after the LAD crossover staining, and there will be a very tight lesion in the ostium of diagonal. But whether the diagonal the stenosis is significant or not, intravascular imaging cannot answer this question. So we have to do more. And there's very important points of bifurcation lesions, and we have to focus on. One is if we should do or not the intervention. Another one is if we should treat the Sept branch, especially after the main vessel staining, just a balloon or just put a stent here. And another one is what is the effect after we just do the intervention, if the blood flow is good or not. So if we just want to answer these questions, we have to figure out, for example, the size of myocardium, and if the Sept branch is significant or important enough, and if we can just take the consequence if we would just lose these Sept branch. And to answer this question, we have to do the functional assessment, and it's much more important for the bifurcation assessment. And the most important tools for the functional assessment is FFR. And as we know, the fractional flow reserve is a parameter that evaluates the physiological function of coronary artery disease just based on the measurement of the pressure. And it is defined as a ratio of maximal myocardial blood flow in the presence of stenosis to this radical normal maximal flow in the same distribution, and that can help us to understand the bifurcation lesion better to overcome this complexity, and can just truly assess whether the Sept branch lesion just causes the myocardial ischemia, and the ischemia just doesn't matter. And there is some researchers just to support the FFR application in the PCI with bifurcation lesions. One is from just the same author from China, Professor Chen Xiaoliang, DK Crush 6 trial, and there a total of 3.20 patients enrolled in the study, and all of them with true bifurcation lesions, and with the PCI using the provisional strategy that makes the Sept branch intervention strategy when necessary. And those patients were randomly assigned to receive either FFR guidance versus or just angiography guidance. And up to 1 year follow-up, the patient from the two groups had similar clinical outcomes, but the patient undergoing PCI with FFR guidance, lower proportion of side branch intervention, and also the lower proportion of side branch standing implantation. That means this kind of patients, if we treat it using the FFR guidance, we could avoid unnecessary side branch intervention. And actually, in the real world clinical practice of the PCI and bifurcation lesion, the FFR play very important role, and in pre and post PCI and during the procedure. And we just introduced the fact from the 3 points. For the pre-PCI assessment, there is for the left-hand bifurcation is a little bit different from the other bifurcation lesion because, as you know, the left-hand is much more important. And in the treatment of the left-hand lesions, FFR can provide information that cannot be obtained by intravascular imaging and guide optimal intervention treatment strategy. And standard implantation strategy can be guided by measuring the FFR value and at both side branch and respectively, and before intervention for evaluating the left-hand bifurcation, especially the distal bifurcation. And the stenosis of the LAD and circ and can lead to, as you know, the underestimation of the severity of distal left-hand lesion, and the FFR value of the left-hand also decreases when LAD or circ stenosis is relieved and or the change. So FFR values of left-hand must be measured again after side branch stenosis is treated to decide whether the standard implantation is required and to avoid some missing important lesions. And there's some examples below, and in some very difficult or complex distal left-hand bifurcation lesion, I think the combination of the FFR and intravascular imaging could provide more insight into the anatomy and functional issue. And another issue is the pre-PCI assessment of FFR for non-left-hand bifurcation lesions. And in the treatment of the non-left-hand coronary bifurcation lesion, FFR can only give the pre-functional assessment of severity for the main vessel only, except for the bifurcation lesion with ostium lesion on the branch. And the side branch diameter also should be more than 2 millimeter, less more than 40 millimeters, stenosis more than 50%, and the lesion depth should be less than 10 millimeters. So it should be focal, but very tight, and also the side branch is important enough that FFR could just do a better job. And
Dr. Zheng, I'm sorry to the disruption. Could you adjust the microphone? There is a little after sound. 有点回音，我们听起来。
Okay. Is that better?
Yeah, I think so.
Okay. Okay. And there is, I think, the most clinical scenario is just a provisional strategy, and after the main vessel setting, and there would be some change of the ostium or side branch, and that is the question, and how and when we do the provisional the side branch intervention. There are some criteria from different clinical study. For example, the tiny flow less than 3, and the ostium of the stenosis greater than 50%, and also some dissection or just a threatened closure or something like this. But that, I think the trial did not include the functional assessment. But as we know, the mechanism of the side branch compromise after neurological setting, the most important thing is a cranial shift. And also, we have some different mechanisms such as plaque shift, spasm, thrombus, stance rods protruding into the ostium of the side branch, and so on. And so we cannot differentiate. We cannot to figure out whether it is significant as only by the imaging, only by the angio, only by the intravascular imaging. So we do have to evaluate the functional ischemia. And there is the example, as we see. After the main vessel setting, the diagonal and very tight lesion here, ostium, but the FFR value is just 0.81. It's not significant. And also, there's no significant perfusion defect on the radiographic imaging. So it should be deferred. We don't need to treat that at all. And there's some data from different registry, observational, and some sub-study, and we could see that there's no linear correlation between the angiographic gnosis and the functional ischemia. And there's some recent study that focus on the application of the FFR on the predictive value of the bifurcation lesion. And there's a study, just 83 patients with abdomen and bifurcation lesion, and underwent FFR assessment for the circ after the IAD abdomen crossover stenting. And post PCI circ FFR, we could just group up by a cutoff value of 0.8, and all of the patients did not receive further treatment, further intervention of the circ, and up to 5-year follow-up. And we can see that if the circ FFR is less than 0.8, there will be increased risk of the target lesion, revascularization, target lesion fear, and compared to the high FFR patient. So the FFR value just doesn't matter. And another one is the FFR guided side branch intervention. And the study is from South Korea, from Professor Koo. And in this study, it's 108 patients with bifurcation lesion undergoing PCI with provisional strategy. We wrote, and 91 patient had FFR at the jailed side branch. It's measured after the main vessel setting, and when the FFR of the side branch was less than 0.75, it decided to treat the side branch. And as you see, and the FFR value just increased, elevated significantly after the side branch intervention, after the kissing bone. And then after the 6 months follow-up, you see the FFR value just kept and consistently just after the procedure. So the FFR guided side branch intervention just kept for at least 6 months in really this manner. And the FFR application and the pre-intervention and the post-main vessel crossover stenting and after side branch bone dilation and various form. we could see FFR could use the main vessel and Sept branch osteomyelitis before the intervention, and also after the main vessel cross stenting, and we could just measure the main vessel again, and then to measure the functional, the significance of the larger jailed Sept branch. It is the most important issue we just focus on. And after the Sept branch treatment, for example, kissing bloom, we could evaluate the effect of the treatment again. And also, we could just assess the residual ischemia post standing of the main vessel. And but there's some scenario we could not use the FFR. For example, it is the very small Sept branch and diffuse lesion, calcified lesion, or the Sept branch has very slow or even no reflow after main vessel stenting, and also some very significant dissection. And also, there's the issue the FFR cannot predict outcome just post the double standing strategy treatment. So it can only the provisional strategy. But even FFR have some advantage, but it is have some very obvious limitation. For example, if we just treat a very tight osteum, very sharp angle, and other conditions of Sept branch bifurcation, and we cannot, even it is difficult to just manipulate the pressure wire, just passing the Sept branch and increasing the difficulty and the time and even the risk of complication. And also for the FFR, we have to use the vasodilator. So for example, adenosine or ATP in China, and this kind of drug can just increase the risk of the discomfort of the patients, and also even some compromise, hemodynamic compromise. And also there might be some poor repeatability, something like this. And just for this kind of reason, recently there is emerging technology that is the angio-based FFR to overcome this kind of disadvantage I mentioned about. For example, the FASH angio CFFR system, and it's could do the multi-vessel reconstruction for the bifurcation lesions based on the angiographic images only. And also, it is very important, just to mention by Bob, there is combined the real-time LT pressure. We have the LT pressure just waveform that we can do a lot of further calculation. And also, we just have the angiographic blood flow velocity, and by the different counting very carefully, and we could measure the pressure gradient in the FFR through the CFD, computational fluid dynamics. And definitely we have some advantages. Number one, there's no need to use the pressure gun wire again. There's just no wire. And number two is no need for these vasodilator drugs, no adenosine, no ATP. And number three, no additional procedure and manipulation. And number four, it can distinguish the FFR value of the stenosis part of the bifurcation lesion and under the separate action.
好像什么 costing 我讲要 costing 还是要安全，哪一个重要？
什么 costing？
And just based on this technology, we just initiate a clinical protocol of study and to validate the performance of the FASH, angio, and the CFFR on the PCI with the coronary bifurcation. And for the coronary bifurcation lesion, it's based on the image data of the angiography and just interpositions combined with real-time LT pressure. And we do the vascular reconstruction and flow calculation. And the accurate determination of the FFR and the stenosis of coronary bifurcation is realized. And I think that's through the flash angio CFR systems. And here is a protocol. And this study is a randomized control study in a patient with stable coronary artery disease or the non-ST elevation cardiac infarction, or the patient with previous and prior ST elevation cardiac infarction, and with bifurcation lesion. This can be included in this group. And there are 2 projections of angiographic images admitted at least. And the subject's angiographic images meets the standard, the subject will be randomly assigned to the group, either based on the flash angio FFR or just angiographic images only to make a decision and how to treat this kind of lesion. And for example, all the bifurcation lesion using the provisional strategy and just randomly to receive either flash FFR or just angio guidance. And for the flash FFR guys, it's based on the diagnostic strategy by the CFFR, and the jailed cell branch after the main vessel staining will be evaluated by the flash system, and the treatment strategy was determined according to the CFFR values, and the treatment was performed according to the clinical practice standards. And for the control group, the angio guidance only according to the angio imaging, and the bifurcation lesion was revasculated by the operator experience only, and the follow-up will be 3 years. And here is the inclusion criteria, and 18 years old or older, and patient with just stable coronary disease or just stable and standing, and for the imaging inclusion criteria, it should be the true bifurcation lesion, the manual type is 111 or just 011, and 40 to 90% diameter stenosis in the cell branch after the main vessel staining and bifurcation. And also the cell branch diameter should be greater than or equal to 2 millimeter. And here is the exclusion criteria. And for the coronary angiography exclusion criteria should be there's no myocardium breach that will be influenced the FFR value, and also there's no severe tortuosity of the target vessel. It could be influenced the control of the margin vessel, and also a severe overlapping of stenosis segments. They could be very difficult to control the vessel margin, and also the poor image quality and able to identify the vessel control, something like this. And endpoints. The prime endpoints is the composite endpoints, which, including the set branch vessel, balloon inflation, the POVA, or just the set branch vessels and implantation, and impaired TIMI flow in the set branch, and the periprocedural myocardial function according to the SKY criteria. And the secondary endpoints, including the target vessel failure or the myocardial infarction, in 1 month and 12 months. And here the flow chart. And after the main vessel staining for the true bifurcation lesion, and we just measure the CFR for the set branch. If the CFR for the non-Neptunian bifurcation greater than or equal to 0.75, or for the Neptunian vessel for the circ greater than or equal to 0.8, we just default. We will do nothing. And if it's less than this value, and we could just treat the set branch, for example, to do kissing bloom, or if there's a dissection or very slow flow, we might do the provisional staining for using the tap technique and measure CFFR again until the CFFR value greater than 0.75 or greater than 0.8. And for this study, I think we just have to verify the accurate determination and of the coronary artery bifurcation lesion that using the fresh FFR system, and we just hope to provide a setting of to guide diagnosis and treatment plan for the bifurcation lesion of a new strategy, and hopefully maybe it could improve the long-term prognosis, quality of life, and decrease the interventional risk, and also economic burden for the majority of patients with coronary bifurcation lesion. And here is a case we just present. Here we could see from the right end caudal view, we could see there's some very tight lesion in the proximal part of the LAD and with very severe calcified lesion. And from the right cranial, we could also see a very diffuse lesion in the LAD. And also we have two bifurcations. One bifurcation in the LAD and in the diagonal. Another one is the LAD circuit and disallotment. And from another view, the spider view, we could also see there is very tight lesion in the proximal LAD, and also there might be some lesion in the proximal circuit and the osteoid circuit. So how we can just evaluate these two bifurcation and how we could do to make a decision to do the PCI. Firstly, we just do the CFFR to assess the main vessel from the left to this LAD, and the CFFR value is 0.69. It's very, very significant. So the indication is confirmed. We should do the PCI for this patient. And then we just evaluate the CERT with the CFFR is 0.94. So at least at baseline, the CERT is not significant, but we will see what's going on after the main X-ray scan. And then because it is very, very calcified lesion, diffuse lesion, and complex enough, so we have to do the intravascular imaging guidance, and there's OCT. From the OCT, we can see just a diffuse lesion with very severe calcified lesion, almost 360 degree, and very thick lesion, very thick calcified plaque. So just we do the rota. We do the rota ablation, and here's the rota, and we're using the 1.5 and 2.0 burn to do the rota, and it is, I think it will work, and it has. And after that, we're using the broom to do the predilatation, and as the fully dilated, and then put the stent firstly from the distal to the middle part of LAD with the stent 2.5 33 millimeter, and then do the post dilatation. You see with the 2.5 and the 3.0 the NC broom, and then we do another stenting and using the gel broom technique, and we put the broom, a tool broom, into the diagonal, and then we just do as you see, the post dilatation for the second stand again using the 3.0 quantum NC broom, And then we do the 3.5 frequency bloom to delay the proximal part of AD. And finally, implant a stent with the 3.5 and using the jail bloom technique again to protect the circ. After that you can see there is some tight lesion with some change in the Austin circ. So at that time, we just do the CFFR again. And the value, as you see, the value is 0.8. It is both line, but as you see, the circuit is huge. I think it's very important. So we just decided to do the casing bloom for the circ to ensure there is no very significant ischemia after this kind of PCI procedure. And we just do the casing bloom. You'll see using 3.5 quantum for the LAD and 2.5 bloom for the circ. And here the final imaging. It's not bad. I think the stent is fully expanded. And also from spider view, I think the Austin, the circ is getting better. But most importantly, we just measure the CFFR again. And for the LAD, it's from the 0.69 to 0.9. And for the circ, it's just back to the 0.94. And for the LAD, for the circ, for the diagonal is 0.93. Okay, and here the take-home messages. We can just summarize my presentation. The functional assessment really does matter, and the PCI with bifurcation lesion, and the FFR could play a very important role in the pre-procedure assessment, decision making during PCI, and also the evaluation post PCI with coronary bifurcation lesions. And the angio-based FFR, for example, the fresh FFR system could provide equivalent effect on the side branch evaluation and just of the FFR and avoid additional risk and cost. And also some further investigations, just like ours, are needed to validate the hypothesis. And thank you for your attention. Thank you.
Okay, thanks very much for Professor Zheng's introduction. It's helpful for us to understand the features and benefits of FFR system on the bifurcation diagnosis. Okay, now let's have a 10 minutes break. During the break, you can drop your questions into the studio, and we will collect them and answer the question at once. At the same time, Nick will drop a questionnaire link into a studio. So we need your help to give us some feedback on the webinars. So, okay, we will be back in 10 minutes. And during the period, we need your help to give some evaluation of the questionnaire. And you can prepare your questions. Thanks.